Good afternoon and welcome to the latest instalment of our Kirby seminar series. Today, the presentation is called SARS-CoV-2, Vaccines, Variants, and a Glimpse into the Post-Pandemic Future. It will be given by Professor Raina MacIntyre, who's head of our Biosecurity program here at the Kirby. And Raina's expertise in this area has been recently recognised by the award of an MRFF grant to develop AI approach to early pandemic detection. Before we start, I'd like to acknowledge the traditional owners of the land from which we all join this seminar today. I am joining from the lands of the Bidjigal people of the Eora Nation, and I pay my respects to their elders past, present and emerging, and extend that respect to any Aboriginal and Torres Strait Islanders who are joining us virtually today. In terms of how this works, for those of you who are joining us for the first time, I'll shortly hand over to Raina, who will present the seminar. We will keep time at the end for questions. We have received some questions prior to today, and we will try and include those. But if you want to add questions for Raina to address at the end of the seminar, then please go to the icon with the question mark in the middle of it. Click on that and add your question. It would be great if you could identify yourself and if you like a question, you can upvote it on that same through that same icon. So without any further ado, I'll hand over to Raina to present today's seminar. Thank you, Raina.
Okay, I too would like to acknowledge the Gadigal people of the Eora Nation, which is where I'm speaking from at the moment. And I'll start with this nice graph from the New York Times, which says the pandemic is split into two, which is essentially telling us what's happening around the world today. And in the red, you can see Goa and New Delhi from India and Buenos Aires. And then in the green, you can see countries that were very badly affected even earlier this year that are now coming under control with very high rates of vaccination, including Israel and cities in the US. So we're seeing this divergence of disease control. This is from Our World in Data, the percentage of people, the share of people who've received at least one dose of COVID vaccine. And you can note there that the UK, Israel has one of the highest rates, not the highest, that's the Seychelles, we'll come to that in a minute. Over 60% have received one dose. The UK, over 50% have received one dose. The US, somewhere around 46%, I think, have received one dose. Australia, it's actually around, it's close to India, which is around 12%. I think India is at about 10%. Australia is at about 12% at the moment. This is looking at the percentage of people who've been fully vaccinated, so had both doses or one dose of a one-dose schedule, and Seychelles is at the top there, over 63%. Israel is almost 60%. And this is interesting here because in the US and the UK, it was reversed in the number of people who got the first dose. The UK was ahead of the US. The reason for that is that the US was using either a one-dose vaccine, the J&J, or the mRNA vaccines, which are spaced apart by 3 weeks, whereas in the UK they made the decision to split to space the doses by 3 months. So there's a very long delay between getting your first and second dose, which is why the 2-dose completion is higher now for the US. Here we're looking at daily new COVID cases per million people. So this is adjusted for population. And this is the Seychelles here, which is very highly vaccinated, but is having this huge surge in cases, which is very interesting. Whereas for the other countries that are highly vaccinated, we're seeing a dramatic decline in cases. In our region, Singapore is the green line, India, and this is cases per, sorry, I'll come to the cases in a minute. This is the percentage of people have received at least one dose. So Singapore is quite highly vaccinated. About 35% of people have had one dose. India, Japan, Australia. Taiwan has very low vaccination rates, and we'll talk a bit about Taiwan in a moment. Fully vaccinated, Singapore is less than 30%. India is less than 5%. Japan is very low. So here's the case numbers then for our region, and you can see that the case rate, it's very high for India. Japan is also seeing a surge in cases. Taiwan and Singapore, the relative rate is lower, but when you look at the two inset graphs, that's Taiwan at the top, which is dominated by the UK variant B117, and they've had this big surge linked to problems with how they organise their hotel quarantine. And then Singapore is seeing a surge in cases linked to the B16172, which is one of the Indian variants, which has prompted schools to be closed just this week. So the wash up of the efficacy data from the trials for the different vaccines, and I've organised them by the technology. mRNA vaccines seem to have the highest efficacy. The blue is against the D614G strain, the dominant strain last year. The orange is the B117 or the UK variant, and the grey is the South African variant, the B1351. I've made the Johnson & Johnson one there a bit lighter in colour because it's a different endpoint to the other trials. They looked at prevention of moderate to severe disease after one dose rather than symptomatic infection. But you can see that the mRNA vaccines give pretty good protection even against the variants, as does the Novavax, the protein vaccine. The J&J is not bad. The AstraZeneca gives good protection against, symptomatic disease, particularly severe and hospitalizations and deaths, but has pretty low protection against the South African variant. The Gamaleya, which is the Russian Sputnik vaccine, there's been a letter in the Lancet questioning the data in that trial, and there are some very odd discrepancies in the data, and the authors of that trial haven't released the original data despite requests. So I think there's a big question mark around that 91% efficacy. They also showed in the trial that every single age group from young people to very old people all had the same efficacy of about 91%, which that just doesn't ring true. So I think there's some question marks around that trial. Sinovac, it looks bad here. This is a whole virus inactivated, but that data comes from a trial done in Brazil where the dominant strain was actually P1, which does have some vaccine resistance. So it's probably not a bad vaccine at all if it's giving you 50% efficacy against symptomatic disease where P1 is dominating. That's the Brazilian variant. Sinopharm, apparently 79% in clinical trials, which is also a whole virus inactivated vaccine. People are interested in the mixed dose schedules or heterologous prime boost vaccination, where you get one vaccine and then another. And this has just been published in the Lancet, and essentially what it shows is that if you mix the AstraZeneca and the Pfizer, this was done in the UK, you get a higher amount of side effects, not serious side effects, but both systemic and local side effects. This was only low numbers of people though, in the hundreds. So it wouldn't be able to tell you anything about rare side effects. So let's just go through those countries that have achieved high rates of vaccination and have a quick look. Israel, 62% at least one dose, almost 60% fully vaccinated. They had B117, the UK variant, dominant through that time. They saw this dramatic reduction in hospitalisation and deaths and infections in older people who were vaccinated first. And that's the blue graphs up here, and different positive cases, positive tests, hospitalizations, new severe cases. And then they started vaccinating the next age group down, and the younger and younger groups. And you can see that even in the 20 to 39 age group, the rates have peaked and started coming down. which is really good. One of the effectiveness studies showed 92% protection against asymptomatic infection, which is really good. And that was repeated in another study published in The Lancet, which showed 95% protection against infection and 91% against asymptomatic infection. And that's actually really important because that's a determinant of whether or not herd immunity is possible. In the UK, this data comes from Public Health England, 53% at least one dose, 28% fully vaccinated in a period where B117, the UK variant, has been dominant. And they've made estimates of the effectiveness after 1 and 2 doses. There's only 2-dose data for the Pfizer because it's got a 3-week interval. There's only 1-dose data for the AstraZeneca, and it's looking quite good for both vaccines. The level of confidence around those estimates is in the green is high confidence. Here's the US, 46% at least one dose, 36% fully vaccinated. B117, the UK variant's been dominant. mRNA vaccines have been estimated by the CDC to be 94% effective after 2 doses. So reiterating what was seen in Israel, and 80% effective after 1 dose, which is great news for countries that have shortages of vaccines. Meaning you could, there's also been another study which I didn't include in this presentation, which shows that if you space the Pfizer out 3 months instead of 3 weeks, in much older people, over 80, over 90, that you get a much better immune response because older people, due to immunosenescence, do not respond as well to vaccines, any vaccines. So that means, you know, you can space out the dose of Pfizer for potentially up to 3 months if you really need to, and, you know, wait for more supply and vaccinate more people with 1 dose. So they've seen really a dramatic decline in deaths. It's come down to its lowest level in the pandemic. Qatar is another interesting case where they had 2 epidemics, one caused by the UK variant and one caused by the South African variant, which is the one that is the most resistant to vaccines. So the B1351 or South African variant is the one where the AstraZeneca vaccine has only 10% efficacy against. But they found the Pfizer vaccine was effective, 89% effective against the UK variant and 75% against the South African variant and 100% effective against death from the South African variant, which is very reassuring. Now let's move on to the Seychelles, which is very interesting because they've had 62% of the population. I think the population's only about 100,000 people, so it's a small country. It's a little island in the Indian Ocean. 71% have had 1 dose, 62% 2 doses, and it's a mixture of Sinopharm, which is the whole virus inactivated vaccine that had 79% efficacy in the clinical trial, and AstraZeneca, 43% got AstraZeneca, but AstraZeneca was given to people over 60 years of age. And they've seen this huge surge in cases. I've put the inset of the graph there, the green line, which I showed you before. And 37% of the new cases are fully vaccinated people. And 20% of hospitalized patients are fully vaccinated. So what's going on? Is it variants? There have been reports of the B1351 in Seychelles. That's the South African variant, which is very vaccine resistant, but there hasn't been comprehensive genomic surveillance. We know that the efficacy of AstraZeneca is very low against the South African variant, so that in itself could account for it, especially because the older people were getting that vaccine. There's no vaccine efficacy data for Sinopharm against B1351. But the lab studies do show that there is some reduction in neutralizing antibodies against the South African variant, but probably reasonable protection. So the possible explanations for what we're seeing in Seychelles is that, one, the herd immunity threshold hasn't been reached. And if you saw my last talk, I gave quite a full explanation on herd immunity. 62% just may not be enough. Maybe it needs to be 70% or 80%. It could be that herd immunity is unreachable due to inadequate efficacy against all infection. So you have to stop both symptomatic and asymptomatic infection to stop transmission. It could be that variants with vaccine escape are dominating the transmission in the seashells, so it could be mostly B1351, we don't know. A very probably unlikely possibility is for some reason they've had mass cold chain failure. So I think it's probably the herd immunity threshold hasn't been reached, plus or minus if it's the South African variant in there. I'll have a conversation piece coming out on the seashells, so just keep an eye out for that. This is from our study, which was published in Vaccine. I talked about it in my last presentation, but again, to reiterate that the vaccine efficacy matters in terms of the kind of control you get. And if you look at that purple line in the graph, that is vaccine efficacy of 70% against any infection, symptomatic and asymptomatic, right? So anything not as good as that is not going to give you can see that's kind of where the threshold for good control, right? After that, anything that's lower than that, the epidemic just blows out. So I'll also point you to this graph from the Lancet trial of the AstraZeneca vaccine. They never presented data on efficacy by age group, okay? This is the only thing they presented by age, which is the anti-SARS-CoV spike IgG response 28 days after the second dose in people getting 2 standard doses and with the longer interval as well. This is a logarithmic scale on the y-axis, okay? So the differences there are big differences. And you can see that in people over 56 years, the responses are not as good, okay? They are just not as good. There's quite a difference when you compare it with younger people. So that could be partially explaining what's going on in the seashells, the combination of B1351 plus the older folks getting the AstraZeneca, which just doesn't have as strong an immune response in older people. So let's talk a bit about the Indian variants. There's the B1617 and the B1618. There's been some studies around the mRNA vaccines which show that there is some resistance, neutralization resistance, but that probably the effectiveness is pretty good still against these Indian variants. So it doesn't seem to be as vaccine resistant as the South African variant, which is good news. Here's what's happening in the UK, and this yellow line here is the Indian variant B16172, and you can see it's really overtaken everything, particularly in the northeast of England. This is the dominant strain now. This is from Andrew Rambo in the UK, which he posted on Twitter, which just shows you how dominant this Indian variant has become pretty rapidly, really, since March in the UK. And this is from Public Health England. They have assessed that this Indian variant it's highly likely that it's more transmissible than the UK variant, which is already, the UK variant, remember, is 50 to 100% more transmissible than the old strain D4, the one that was dominant last year. And they're saying that it's as much as 50% more transmissible than the UK variant. So this is super transmissible and could certainly explain what we're seeing in India today. There's also biological plausibility around the mutations present in the virus. They also say that in areas where the number of infections are increasing rapidly under the current restrictions, that they would expect an even faster increase if measures are relaxed. So that's a big warning about relaxing things, even though they've got reasonable vaccination rates. So they are predicting that they could have a resurgence in infection due to this Indian variant in the UK. So I think we just need to wait and watch and see what happens there. This is from Trevor Bedford. His analysis again showing the rise in the Indian variant in the purple there, the B1612, whereas the B16171 is decreasing. So it seems that the B16172 has a fitness advantage. And this is around the world. Now, the blue line is the B117, the UK variants. This is also from Trevor Bedford. If you just look at the red line down the bottom, that's the Indian variant, okay? And you can see that it's increasing everywhere, which is a real worry. So in northwest of England, sorry, I said northeast earlier, but it's in the northwest, where the B16172 is circulating, there is this resurgence in cases, but it's in younger unvaccinated groups, right? It's in the children and young adults who haven't yet been vaccinated, which means that that unvaccinated group is going to be the susceptible pocket because we can't vaccinate kids yet because the trial data aren't available, the youngest kids. This is going to be the same story everywhere. As you reach higher vaccination levels, it's the kids who are going to be susceptible. So then I've gone to nextstrain.org, which is Trevor Bedford's site, where they take the data from GSAID and give you the information. This is in the UK, and the green is the Indian variant, okay, and the red is the UK variant. You can see that taking off in the UK over time. So this is giving you a snapshot over time. In the US, not as big a problem. It all seems to be the UK variant is much more dominant. Italy, though, there's been a huge rise in the Indian variant. Japan as well. There's been some of it around. Here it is in India, just overtaking everything. Interestingly, in South Africa as well, which has had, the red is the South African variant, the Indian variant is now taking off. Singapore, the big outbreak they're having at the moment is dominated by B16172, the Indian variant. Bangladesh as well, which interestingly had the South African variant as a dominant strain for the most of this year, is now seeing a rise in the Indian variant. New Zealand had some, but still mainly the UK variant. And here's Australia. We can see that we have had a big increase in the Indian variant, and the pie chart there, so the graph from NextStrain is showing it over time. The pie chart is showing the variants sequenced as of the 5th of May in Australia from one of our students, Danny Hutchinson. You can see that 21% have been the B1617, 62% the UK variant B117, and 10% the South African variant. So this is it was only recently classified a variant of concern. The UK said so first, and then the WHO followed. So the big question about this is, do vaccines stop transmission? And this is kind of new terminology. What we're talking about here is, do they prevent infection, all infection, not just symptomatic infection? We know the AstraZeneca vaccine has 22% efficacy against asymptomatic infection after 2 doses. In Israel, we saw 92% effectiveness against asymptomatic after the Pfizer. In the UK, another study showed 4-fold reduction in asymptomatic infection in health workers more than 12 days after vaccination. And again, in Israel, 75% reduction after 1 dose of Pfizer. And now there's emerging data that vaccination may result in lower viral loads in infected people. So this is that the one I just showed you from eLife Jones et al. The bars are showing you the percentage of positive tests, and you can see that 4-fold reduction 12 days after vaccination. The blue dots are the number of positive tests with a cycle threshold value less than 36, which means they're very infectious. And you can see there's quite a decline in the number of tests that have a low cycle threshold, which is really good. It's telling you even the people who get infected are less infectious. So that actually may come into play when it comes to herd immunity. We don't know. Herd immunity is a function of the R0, which depends on the variants, and we know now that some of these variants are much more infectious. They've got a higher R0. It depends on the proportion of the population that are vaccinated and the vaccine efficacy of the vaccine you're using. There is some evidence from Israel of herd immunity effects of protection of younger age groups who are unvaccinated. And in the UK, another study showed family members of health workers who were vaccinated were protected, but I wouldn't really call that herd immunity. It's too early to tell. Possibly the reduction of viral load will contribute. So the vaccines with lower efficacy like AstraZeneca may still be able to achieve herd immunity. We don't know if they reduce viral load in the people who get infected to such a level that they're not infectious or minimally infectious. This is from our paper in Vaccine showing if you vaccinate 70, if you have a vaccine that's 95% effective, you can achieve herd immunity with 63% of the population vaccinated. If it's 90%, 66% vaccination. If it's 80% effective, 75%. If it's 60% effective, you need to vaccinate 100% of the population. Anything less than 60% cannot achieve herd immunity. So that could be why we're seeing a big surge in the Seychelles, maybe. We don't know. Booster doses, of course, may be needed if the duration of immunity is short-lived. People think it's highly likely we're going to need boosters. The frequency is unknown yet because we've only had about 8 months of follow-up of people who've been vaccinated, although we've got longer follow-up in the people in the trials from last year. There are multiple vaccine manufacturers are now making boosters targeting the variants of concern. The vectored vaccines, so the adenovirus vectored vaccines, have a disadvantage because if it ends up that you need an annual vaccine, the adenovirus vector itself stimulates immunity to the adenovirus. So with more and more doses, you develop immunity to the vector, which means that the effect of the vaccine will be reduced because your body will block that vector. So that's a disadvantage of vectored vaccines, the need for multiple long-term boosters. This is a study that's just come out from researchers at the Kirby Institute, David Curry, Deborah Cromer, Miles Davenport, etc. Shout out to them and this great paper in Nature Medicine. And again, they're showing the choice of vaccine matters by the efficacy. So with your starting efficacy, the red line is if you start at 99% efficacy. The pink line, if you start at 50% efficacy, they don't decline. The immunity doesn't wane in parallel. It wanes more. So if you start with a higher efficacy vaccine, you'll have, better protection in the longer term. Is the message from this study. So I really recommend you go and look at this study. Of course, there's lots of people working on universal coronavirus vaccines now. This paper came out at the end of April, which is a vaccine that targets multiple different antigens and could cover a range of bat and human beta coronaviruses. But there's other approaches as well in terms of looking for conserved regions of the virus that don't mutate and trying to elicit immunity in the same way that the search for a universal flu vaccine has been going on. So where are we traveling and do vaccine choices matter? There's the plane seat that you've never seen for the last 12 months. I haven't been on a plane. So I'm going to just talk briefly about this study by Frank Sandman et al. From the London School of Hygiene and Tropical Medicine, which is the first full economic evaluation of vaccination and SARS-CoV-2. And what they looked at the UK, they looked at a range of non-pharmaceutical interventions like lockdowns and the economic cost of those lockdowns, right? So they factored in the cost of disease, the cost of lockdowns, the cost to the economy of all the different non-pharmaceutical interventions. And they had a no vaccination scenario, a worst case vaccination scenario, and a best case vaccination scenario. In the worst case vaccination scenario, the vaccine has 50% efficacy against disease and only lasts about 45 weeks. And in the best, so short duration of efficacy. And in the best case scenario, the vaccine has 95% efficacy and protects you for 3 years. Okay, so you can imagine when you're looking at these graphs, there are areas in between, depending on how good your vaccine is. And then they had looked at different triggers for lockdowns, right? The number of cases, the incidence of disease that would trigger a lockdown. And essentially, in terms of numbers of cases, so you've got no vaccination here on the top, numbers of cases, worst case vaccination scenario, best case. And this goes across all the different analyses I'm going to show you. Essentially, the worst case vaccination scenario is not very different to no vaccination, right? If you're using a poorly efficacious vaccine that's not going to last very long, it's almost as bad as no vaccination. So the choice of vaccine really matters. The higher the efficacy, the better your scenario is going to be. Then they looked at the quality adjusted life years and the net healthcare monetary value of vaccination, no vaccination, vaccination, best case and worst case scenarios. The best case is in the orange, the worst case is in the blue. And you can see that essentially the big take-home message is your worst case vaccination scenario where you're using a low efficacy vaccine that doesn't give you long protection. It's not very different from no vaccination at all, right? And your costs are going to end up the same because your disease costs are going to be so high. And here they looked at the net monetary value by 10% daily GDP loss, 15%, by 2%, 5%, 10% and 15% daily GDP loss. And as, again, you'll note that the best economic scenario is with a high efficacy vaccine, the best case scenario, right? That's the red line. Whereas when you've got your worst case vaccine scenario, it's almost no different. It's pretty similar to no vaccination, right? And I think this is really important. Governments everywhere should understand that the vaccine you choose really matters in terms of long-term economic impacts. So let's move on just to borders. We know that border closure works. We've seen it in New Zealand, in Samoa, in Australia. But while vaccination rates are low, the risk of outbreaks persist. And we're seeing that right now in Taiwan, very low vaccination rates. They made a huge mistake in promoting domestic tourism in local hotels that were housing returning aircrew. And of course, that set off an outbreak. Variants of concern raised the stakes just that much higher. And the pandemic now is much worse than it was a year ago. So the risk of infection coming in is much greater today than it was a year ago. Without addressing the airborne transmission of the virus, which means addressing ventilation, selecting quarantine venues based on ventilation, and giving people airborne protection, the risk of breaches will continue. Australia has given out over 3 million doses of vaccine, so about 12% of the population has had one dose. 70% of that is AstraZeneca, so most of this is going to be incomplete vaccination because there's a 3-month lag to the second dose. So we're going to take a while to get to that full vaccination coverage. When you open borders, you've got to consider your vaccination rates. Really, they need to be high. They need to be more than 70%. Need to look at the incidence of infection at the international origins that you're considering letting people in from or going to. Need to look at repatriation policies. And I think it's a really sensible thing to give people vaccination at the origin. Australians who want to come back in, who are in hotspots, vaccinate them before they come back. And have, you know, a good quarantine system. I think it's entirely possible to bring home stranded Australians through those kind of policies. Well, I think maintaining quarantine is going to be important in some form for some time. Interim travel bubbles are definitely possible, but they need to be planned systematically, they need to be flexible, and they need to be informed by data. So here's a study we did last year, more than a year ago now, which was to look at the travel ban to China. So remember, we did a travel ban to China first before we moved to closing the borders in March. This is just to show that our model, this was work by our PhD student, Valentina Costantino. It's in her PhD thesis. The model fit the actual observed data really well to tell you it's a good model. We looked at travel data, the volume of travel coming in and out, the incidence of disease in China, and the risk of importation of infection. And essentially, the blue graph is without a travel ban, and the red is with the the red graph is without the travel ban, the blue is with the travel ban. We averted a very large epidemic by implementing that travel ban. And the same story goes for closing the borders, for which the hotel quarantine has been an integral part. I think we can't forget that the hotel quarantine actually has been a really important part of our success, but it can be improved a bit more to make it safer with those airborne precautions. Then we looked at, could we lift the ban and look at a partial lifting of the ban to get international students in? And remember that that's been part of the economic impact is, international students, universities are the third contributor to the economy in Australia after coal and mining. It's a huge item in our economy. That's why the rental markets crashed, because there are no international students. That's why the hospitality industry has been hit, because their usual workforce is often international students and, travellers and people coming in. And international students also consume hospitality in big cities like Sydney and Melbourne. So it's had a huge domino effect on the economy. So we looked at, based on the amount of cases in China at the time, looked at different times of opening up and letting in students. And you can actually do it if you consider how much disease there is in the country of origin, and then open the borders selectively based on it. It's like that travel bubble idea. So we can do it, just needs to be informed by data. I think my prediction about vaccine passports is they will be a thing. We'll see hotspots of COVID persisting many years globally. I think the passports will be inevitable for going and coming. My prediction is the vaccine you receive will matter. It may determine what kind of quarantine, if any, you need to have. And also when you had the vaccine may determine that, whether or not you've had boosters. We do have a precedent, which is the yellow fever vaccine. So I think it's not completely a new concept. It's something that will become part of our lives into the future. There are some really good lessons to learn from smallpox eradication. Not that SARS-CoV-2 is eradicable, it's not. I've gone through the reasons before why. But the smallpox campaign started in 1967 and they didn't eradicate it till 1980. So that was 13 years. It was a huge undertaking. And India, there were hotspots in the world where they just could not achieve mass vaccination. And India was the last big hotspot in the world where they could not achieve mass vaccination for a range of reasons I won't go into. But one of our students from India published a paper about it, which you can read about the history of it. Vaccine coverage was really problematic, even though they had local manufacturing capacity. So then the WHO changed from mass vaccination to ring vaccination, which is surveillance and containment, vaccinating the contacts. And that's actually how they eradicated smallpox in the end. So I think there's questions there about whether this can be, contact tracing and vaccination is a strategy for SARS-CoV-2. But the other lesson is that global control mattered for every country, right? As long as that was there, we had the last European outbreak of smallpox in 1972 in the former Yugoslavia from someone who traveled to the Middle East and came back with smallpox. Nobody there had seen smallpox for 30 years, so they completely missed the diagnosis and they had a huge outbreak. So this was some work we did on smallpox to look at. This was looking at identifying cases, isolating and contact tracing, etc. Which, if you remember last year, the countries that had really bad epidemics, like in the US and the UK, they kind of just gave up on all this. They all said, too much, too big, can't do digital tracing, we just won't do it. And that's in a way why those epidemics became so big. So essentially, if we can't get global control, we could be looking at something that goes on for years and years. That's what this shows. This is smallpox. Smallpox has a similar R0 to SARS-CoV-2, similar incubation period. We also identified there's kind of a threshold above which the whole thing just explodes and becomes uncontrollable. So I think it'd be good to find that point for SARS-CoV-2 and have a target globally for vaccination rates. I'll skip that one. Just to finish up talking about serious vaccine adverse events. These are all new vaccines. These are not our regular flu vaccines and measles vaccines, things that are tried, tested and well known. they're new vaccines. So rare side effects can manifest post-licensure because clinical trials cannot usually pick up rare trials because of rare side effects because the size of the trials are not big enough. So I think transparency and communication are critical. For the mRNA vaccines, including the Pfizer, which we use here, anaphylaxis and anaphylactoid reactions occur about 2.5 per million doses. Possibly it's the polyethylene glycol in the vaccine. And then the thrombosis and thrombocytopenia syndrome has been identified following AstraZeneca at about 10 per million doses, or 1 in 100,000, and Johnson & Johnson at about 3 per million doses. The fatality rate is somewhere between 20 to 40%, depending on which country's data you look at. Possibly it's actually decreasing over time because of better awareness and management. These are the data from May 5th from the UK, the number of reports and the number that have been fatal. They've had 262 reports and 51 fatal. And you can see they're spread across all age groups. The initial gender difference was probably because the initial vaccine rollout was in health workers who are predominantly female. So that's kind of equalizing. So it's not clear that there actually is a strong gender difference. In Australia, we've had 18 cases judged as likely linked to AstraZeneca from about 1.8 million doses of Astra, which is about 1 per 100,000, same incidence observed in the UK and other countries. The really critical thing is awareness, right? And when you read the case series that have been published on this syndrome, the people who've done badly or who've died, often the diagnosis wasn't suspected, so they were treated with heparin, which is absolutely contraindicated because it can make the syndrome worse. So anyone coming in with a blood clot of any kind should be asked a vaccination history. Have you had a COVID vaccine in the last few weeks? If so, which vaccine, etc. And don't give heparin, which is usually a standard treatment for someone coming in with clots. The antiplatelet 4 antibodies are not a routine test, so most labs won't be able to do that straight away, but you can test for the D-dimer and the fibrinogen level. That could be quite indicative. And I think with that kind of awareness and protocols on asking vaccine history, you can really probably reduce the mortality from it. This is a cohort study from Denmark and Norway, which looked at very large numbers of people, I think about 200,000 people. And the cerebral venous thrombosis really stands out, like 20 times more. The standardized morbidity ratio was 20 times higher. The venous thromboembolism in general as well, pulmonary embolism as well, splanchnic vein thrombosis as well. But the cerebral venous thrombosis seemed to be the most significant one. So after the vaccine, you know, the headaches, abdominal pain, etc., that signals that this kind of side effect might be happening. We did a risk analysis right at the start of April when we started learning about this syndrome for Australia, looking at the risk of dying from COVID versus this thrombosis syndrome, which at the time was termed vaccine-induced prothrombotic immune thrombocytopenia. We looked at a 1% infection rate. That'd be 1%, an epidemic with 1% of people infected would have 25,000 cases. So that's a big epidemic. 4% would be 100,000 cases, right? So those are sort of epidemics that I hope we don't see of that scale in Australia. But we put that in as a kind of a worst case scenario. And we had the zero COVID scenario. So in a zero COVID scenario, you wouldn't be preventing deaths from COVID because there is no COVID. But you could have anywhere between 19 to 461 cases of this syndrome and possibly 4 to 203 deaths from it. In a higher incidence scenario where there is a lot of disease around, a lot of COVID, then you're looking at, you know, still possibly more VIPIT cases and fatalities from VIPIT than fatalities from COVID. And however, interestingly, in Australia over the last year, the infection rate over 12 months was actually 0.13%, so nowhere near 1%. We only had 20 deaths from COVID in people 18 to 59 years. So then we're looking at, you know, if the current management continues, sort of maybe about 20 deaths over the next year, and potentially if we vaccinate everyone this year, then, you know, anywhere from 400 to 200 deaths from the vaccine. Of course, this was before we brought the age cutoff in. Since then, the age cutoff of 50 years has come in, which means people under 50 will be getting the Pfizer. So that changes it, but that was our approach to looking at the risk analysis. Now, just to go back to these being new vaccines, there's a long history of, you know, vaccine adverse events and policy decisions made around acceptability of adverse events. One was the risk of polio from the vaccine. So the live polio vaccine carries a small risk of actually getting paralytic polio. And that's the reason why Australia and many other high-income countries switched to the inactivated polio vaccine, which is much more expensive, more than a decade ago. I think about 15 years ago now. And the risk of vaccine-associated paralytic polio ranged from 0.34 to 0.01 per 100,000. For us, it was worthwhile switching to the inactivated polio vaccine. There was a vaccine called RotaShield, the first rotavirus vaccine that was rolled out in the US to millions of kids, and a rare side effect, intussusception, became apparent. That occurred somewhere between 1.5 to 0.3 per 100,000. The vaccine was withdrawn. And the TTS syndrome with the AstraZeneca, somewhere between 1 to 4 per 100,000, depending on which data you look at. And smallpox vaccine, after 9/11, they started a broad smallpox vaccination campaign in the US, and it had quite a high rate of myocarditis, somewhere between 1 and 12 per 100,000. So that vaccination program was stopped. So the VIPIT vaccine, it's in the ballpark of other vaccines that have had policy changes as a result. So that really justifies the policy change of the age cutoff. Vaccination communication is really important, you know, transparency, honesty, choice, decision support tools. And I think part of it is really important to enable GPs to vaccinate. Mallory Trent, who's one of our PhD students, did a nice study, which was recently published, showing that 75% of people over 65 get vaccinated at their GP. And it's really the younger people who prefer getting vaccinated somewhere else. So in terms of hubs versus GPs, you need to enable, and people want to talk to their GP. My GP, for example, their practice doesn't even have the vaccine yet, the AstraZeneca, they haven't got it. And, you know, if you're like me, you know, a lot of people want to talk to their own GP and get vaccinated by their GP. So I think enabling all GPs to vaccinate is a really key strategy for Australia. I think we need to avoid the trite analogies like lightning strikes and oral contraceptive. Actually, lightning strikes occur at a rate of 1 in 500,000, so it's rarer than the thrombosis syndrome. An oral contraceptive pill, the mortality rate from oral contraceptive pill is not different to people not taking it. So whereas this syndrome has, you know, 20% mortality rate, so it's not an appropriate comparison. Interestingly, in the United States, when they paused the Johnson & Johnson vaccine after this safety signal, it actually increased public confidence in vaccines because the public knew that the safety process was all working, that everything was being done as it should, and, you know, safety signals were being looked at. So I think it's really important to be transparent. I think for us, we need all hands on deck. How fast we get everyone vaccinated really matters. A slower rollout will just have us living with these outbreaks for longer. Ideally, we need to be delivering at least 200,000 doses a day. That was shown by Mark Hanley in some modelling he did, and also in the modelling we did. Mark and his group has also looked at the capacity of mass vaccination hubs and general practices, and got another nice study there looking at the fact that you really need all of those things working at full capacity. You need your hubs vaccinating at full capacity and your GPs vaccinating at full capacity to get us up to speed. And that, of course, depends on adequate supply, including for our commitments to global and regional vaccination and supplying vaccine to the Pacific and other countries in our region. Choice, I think offering choice is important based on some of the research I've seen that's come out on people's views on vaccination. And we need to maintain that ring of steel at the border until our vaccination rates are above 70%, in my view. Globally, vaccination of all countries has to occur. It's just, you know, the Darwinian selective pressure, the higher the vaccination rate globally, the lower the selective pressure for emergence of variants. Otherwise, it's like continually playing whack-a-mole. If there's huge hotspots going on in the world constantly, then we're going to see more and more variants emerging. It's in everybody's interest to get everybody vaccinated as soon as possible. But unfortunately, there is inequity in access to vaccines. Can Australia become a regional hub with increased production capacity for our region? You know, it's really great to hear there's now, you know, serious moves to start mRNA manufacturing in Australia. I think that's going to matter for drugs and vaccines in the future. It's quite a breakthrough technology, but I think the hotspots will persist for years, just like it did for smallpox. Countries that achieve high coverage may achieve herd immunity. I think they will, despite all the negative talk about it recently. We don't know about the duration of efficacy. We probably will need boosters, but that's not an obstacle to achieving herd immunity, not if you can boost people successfully. I think the differences in vaccine, if they're important for herd immunity, will become apparent over time. I think we will have pan-coronavirus vaccines. Last year, when lots of people were saying we may never have a COVID vaccine, I said, yes, we will have COVID vaccines. We'll have many of them. I'm pretty optimistic that we probably will have a pan-coronavirus vaccine as well. And I guess we need to think about the next pandemic and ensuring we never get to this situation again. Thank you.
Thanks, Raina, for that very extensive and thorough review. There have been lots of questions entered, and I think I'll just start choosing some of those. I'm going to try and bring some of them together because there are a number on similar themes. So there are several questions about, and you did go through this, but it might be worth stepping through it again, as to why the decisions have been made that the AstraZeneca has been prioritised for those greater than 50, and how that sort of, I guess, if you could explain how that risk-benefit profile has been decided upon and how that cutoff was decided upon.
Yeah, so different countries have all done risk-benefit analyses and applied the cutoff slightly differently. So many countries use the cutoff of 60. The UK started with 30. Surprised, they're the only country that went that low, but then moved to 40 when they were having, you know, a lot of cases in people in their 30s. It's based on your risk of dying from COVID, right? So your risk of dying from COVID is much lower if you're under 50, whereas your risk of dying from COVID really starts to increase at 50 and gets higher with each decade. So it's based on looking at the risk of dying from COVID versus the risk of having side effects from the vaccine and the rates of the side effects of the thrombosis in different age groups and the apparent increase in the risk in younger people.
Raina, there's also a question, a more of a pathogenesis question around the thrombosis and thrombocytopenia that is seen with the AstraZeneca, but has also been seen with the J&J vaccine, which is also an adenovirus-based vaccine. And the question really was asking you to perhaps speculate on whether that's telling us anything about the pathogenesis of these induced antibodies that drive this thrombosis and thrombocytopenia.
So, I mean, I think you can answer that better than me, Tony, but you know, it's thought to be related to the vectors. Obviously, the AstraZeneca is a chimpanzee adenovirus, whereas the Johnson & Johnson is a human adenovirus. It's very similar to heparin-induced thrombocytopenia, which is a immune phenomenon triggered by the use of heparin, and it's associated with antibodies to platelet factor 4, and it's got the combination of, you know, low platelets but thrombosis as well, bleeding and thrombosis. So they might have cerebral hemorrhage as well as thrombosis in unusual places. It is thought to be an immunological phenomenon. It is thought to be related to the adenovirus vectors. It is quite rare, you know, in a country where, you know, in a country like India where there's a huge amount of disease, you wouldn't use an age cutoff. You'd use the vaccine because your risk of, if you had no other vaccines, you know, to stop the transmission, you'd want to vaccinate everyone. But, you know, and yeah. So I don't know if you want to add anything to that, Tony, about the pathogenesis.
So there, it is driven by antibodies. I guess the question is, those antibodies appear to be cross-reactive, induced by the process of vaccination, and are cross-reactive with a protein on platelets that then precipitate the clinical syndrome of thrombosis and the destruction of the platelets causing the thrombocytopenia. I guess the question is whether it is something in the adenovirus backbone, in the proteins that the adenovirus brings into the body, or whether it's in fact the way the spike protein is presented to the immune system. And I guess the jury's still out on that. And I guess while my initial bias might have been that it might be something about adenovirus vectors inherently, given that SARS-CoV-2 infection has a high propensity of very serious thrombotic complications, you do wonder whether it might be something about the way the spike is presented to the immune system. So I think the jury is still out on that.
So I think there's some theory about release of free DNA as well, right?
Mm-hmm. Perhaps that then ends up the pathogenesis, and precipitates the cascade. Just on further issues about age, there are a number of questions about vaccinating children, which vaccines might be appropriate, and when we might get the data that might support the vaccination of children.
Well, in the US, they're already starting vaccinating 12 and up, so I think it won't be long at all. The trials are all happening, so there'll be more and more data coming in. You know, I think we could expect to also start vaccinating 12 and up later this year, hopefully, or maybe sooner than that. In terms of the very young kids, we have to just wait for the trials to be done and published and the data to be available. And but I don't see any reason why we won't be able to vaccinate under 12s as well eventually.
Thanks, Raina. There are a number of questions around whether people should wait for vaccines. I guess my view on that is, you know, you've observed that a less than ideal an inefficient vaccine may be not different to not vaccinating, but if people don't receive the vaccine, then it's a done deal. The vaccines will not be effective. So I don't know if you want to expand on that.
So there's a difference there, Tony, in terms of the personal benefit versus the population and economic benefit. So those studies I showed you from Sandman et al., etc., were really on the economic effect rather than, so you individually, you know, would be protected from dying from the disease, but you might transmit it to other people and set off an epidemic, and that results in societal costs and need for lockdowns, etc. So that was really looking at a population level and an economic scenario, which is different from, so on an individual level, you know, there's no doubt any of the vaccines available will protect you from severe disease and from dying from COVID and from symptomatic disease as well, and they all protect very well. You know, I think there is an urgency for everyone to get vaccinated in Australia as soon as possible, and it's good to see all the hubs up and running, and you know, we just need to see the GPs fully enabled as well to vaccinate, and some of the other sectors of vulnerable people who haven't been fully vaccinated, like the disability sector, getting vaccinated.
Thanks, Raina. I think that's a great point to end on. I guess just, you know, one of the striking things in one of your early slides was the take-up rate of vaccines in Israel, where they've done clearly an extraordinary job, but it was a little bit concerning to me that the vaccine rate was sort of plateauing at between that 65 and 70% rate, and was sort of you know, topping out at that level, and so you know, the size of the job we have of you know, really prosecuting this widespread population vaccine across multiple countries is really very immense, and even if you start very well, sustaining that and getting it to all populations is going to be a challenge for all of us globally. So thank you all for joining us today, and you know, it's now past the hour, so I'll close the seminar. Thanks very much. Thanks, Raina.
Thank you.